Hello, I am Dr. Subhas Pradhan. I am a psychiatrist. Today, I will be discussing about a very topical and very important issue called suicide, its assessment and management. Suicide has been there since antiquity. Even ancient lords discuss about suicide and have mentioned how people have killed themselves over a period of time. Today, we will be focusing our discussion on these areas. We will be discussing a little about some case vignettes, and we will go on to define what suicide and parasuicide are. We will also be discussing about the prevalence of suicide in the world versus this country, United Arab Emirates, and we will explore about the reasons why people kill themselves, and we will spend some time on how you recognize a person who is likely to kill himself or having suicidal thoughts, and what to do when someone talks about suicide. And in general, we will also be having a little discussion about can suicide be prevented before we will be concluding the talk. Hence, about the case vignettes. In fact, before I define, let's discuss a typical case vignette where a young man calls the suicide hotline telling that he doesn't see any purpose in living anymore since his girlfriend has deserted him. He had been contemplating about killing himself and was looking for ways to carry it out. In fact, a few days before he calls the suicide hotline, he had donated some of his prized stamp collections to one of his friends, much to the amazement as well as confusion of his friend. So this is a typical story that someone sitting in a suicide hotline would be listening to. Let's go to the definitional issues of suicide right now, and maybe towards the end we'll be discussing about what happened to this young man and how we approach his case. We'll be quoting him from time to time. So far as the definition of suicide is concerned, here are the ones that I found quite useful. Suicide has been defined as the death caused by self-directed and injurious behavior with intent to die as a result of such behavior. This intent is very important. There could be some death when the person didn't want to die. We'll be discussing about it later on. Here in the note, it's important to know that the word committed suicide is often discouraged because it connotes that suicide is almost equivalent to a crime or sin, which it is not. Center for Disease Control has also deemed completed suicide and successful suicide as unacceptable terms, and the preferred terms are death by suicide or died by suicide, or some people even use suicide as a verb, like the person suicided. Suicide attempt, on the other hand, is a non-fatal, self-directed and potentially injurious behavior with an intent to die as a result of this behavior. A suicide attempt may or may not result in an injury. There are some terms which are often used interchangeably, although technically speaking they have different meanings. We will not go to the details of those terms in this small talk today, but suffice to say that self-harm and suicide attempt, deliberate self-harm are often commonly used interchangeably, although we should not do that. The terms have got definite meaning in legal as well as medical context. For example, suicidal ideation means the thoughts of suicide varying in seriousness depending on the specificity of the plan. Suicidal intent, as it is mentioned, is a subjective expectation and decision for a self-destruction act to end in death. So, the definitiveness of the act intent. So, I am not going to the full definitions of all these terms. It is important to realize though the terms have got specific meanings, especially in a legal or a medical context. It is very important to discuss about myths, because these are the ones many of us or many people in the community they carry. There are three common myths today I will be discussing. Myth number one: people who talk about suicide are only trying to get attention. They would not really do it. Common myth, isn't it? The fact, however, is this, that few commit suicide without first letting someone know how they feel. In fact, a hovering 70-80% of the individuals, those who talk about suicide, they do suicide is written in their comment, should not be used. They either by making an attempt or complete the act. Hence, the message is, more often than not, people talk about suicide before resorting to that act. Myth number two: don't mention suicide to someone who is showing signs of depression. It will plant ideas in his mind and they will act on it. It's a common misconception. In fact, most of the psychiatric trainees and psychology trainees for that matter, when they do their training, they come with a bit of suspicion when they were asked that you must ask about suicide almost in all interviews when patient gives any indication about feeling bad or low mood, and there is a point behind it. Talking about suicide doesn't cause someone to be suicidal. That is the message. If at all anything you carry today, this is it. On the contrary, the individual can feel relief and has the opportunity to experience an empathetic contact. In fact, a suicide or an interview is not complete unless you ask few questions about how the person feels and whether the person feels like hurting himself or other. Some people even have gone to the extent of telling that suicide or asking about suicide should be the sixth sense apart from the common senses that people have. So every interview one should ask some question about it. It is that important. Well, the third one mentioned here, the suicidal people just want to die. Yes, most of the times suicidal people are torn between wanting to die and wanting to live. But most suicidal individuals do not want death. They just want to stop their unbearable psychological or emotional pain. And they know many a time the futility of it, but the pain is so severe, they possibly think that is, or suicide is a way out, as some people put it. Suicide is a permanent solution to a temporary problem. Well, there are different ways in which suicide has been addressed, especially in the media, and there are do's and don'ts available in many places. This slide shows about what terms basically to, or what to do and what not to do when we are speaking about suicide. I am not going again to the details of it. You can have a look later on from the transparencies. Prevalence of suicide, the world versus UAE. Suffice to say is that suicide is quite prevalent, although its prevalence as such varies from place to place. Let's take a look. Every 40 seconds, someone dies by suicide. If this is not serious, probably nothing is. Imagine, by the time we finish our talk in 30 minutes, how many people would have ended their life. Suicide is the leading cause of death, or the second leading cause of death among 15 to 29 years old. By the way, do you know what is the first leading cause of death? Well, it is motor vehicle accident, or the so-called speed of driving, not speed, the drug. This figure shows the worldwide prevalence of suicide in a very graphical way. As you can see, those in the shade of red shows high suicide, the range of more than 15 per 100,000 population, and it varies from yellow, grey to red. So why does UAE sits in? All right, the figure that you can see is in light yellow, that shows UAE, shows that it is less than 5 per 100,000 population. This slide I got from a study conducted in UAE, where they haven't talked about suicide as such. However, the other causes of death, almost a whopping 25% of other causes of death, include death by suicide as well. The next slide shows this from the World Bank, shows the prevalence of suicide again. It shows an interesting feature. As you can see, the suicide incidence, not the prevalence, obviously completed suicide only has incidence and not prevalence. It is declining over the period of time, last 10 years, from 2008 till 2018. As you can see, it has declined in number. There are some controversies and debates about it, especially thinking about suicide in Islam and in some other religions. How religion protects people from suicide. It is known worldwide that religion and certain religions, particularly Islam and say Catholic Christianity, the suicide rate is low. This study is a cross-national study. It looked at suicide by correlating. They found out the method is that the correlation between general population suicide rate and the percentage of the people in general population adherent to Islam, while controlling for socio-economic status, income inequality. It was examined using a cross-national data from two very widely publicly available sources, World Health Organization and United Nations. The result was that there were significant negative correlation between general population suicide rate and the percentage of people adherent to Islam in males and females, while controlling for socio-economic status and income inequality. Although there is a correlation, it's not necessarily causation. That's something you must remember. In most of the studies, correlation doesn't equate to causation. So in this study, they mentioned that caution should be exercised in attributing a causal relationship and the direction of the causality from this ecological study due to the so-called ecological fallacy. It is suspected that sometimes suicide is underreported because it is proscribed in a culture or in a religion. So we have to keep that in the mind while looking at studies of this nature. Now let's have a look at why people kill themselves. We still don't know the answer for sure, but these are the suppositions. I love this slide, talking from an ecological point of view, a societal point of view. Suicide could be viewed at different levels: individual level or individual reasons, interpersonal level in between individuals, community reasons, community as a whole might have some factors, and societal reasons, the bigger society. So the interplay between individual and interpersonal factors, community factors and societal factors often determine what suicide is. Suicide, it talks about the causes, social causes of suicide. Let's take a look at the next slide. It's one of my favorite slides. Those of you who have been trained in psychiatry or say sociology must have heard about Emil Durkheim, a famous suicidologist, who described 4 types of suicide: anomic, altruistic, fatalistic and egoistic. Let's start with anomic. The anomic suicide talks about due to a breakdown of social equilibrium, maybe leading to bankruptcy or loss of job, loss of family, and this social anarchy that goes to the so-called anomie. In one hand, there is no social cohesion or social regulation. On the other hand, the so-called fatalistic suicide, there is too much social regulations. So social regulation, when it is not there, that makes people prone to kill themselves. So also when there are too much social regulations leading to society's and expectations, and that is too burdensome that they cannot carry and people should remove themselves. For example, at certain age, when you are not earning anything, possibly it is considered not unnatural for people to take their own lives. Altruistic suicide, on the other hand, results from over-integration of an individual into social proof. The so-called integration factor is over, too much integration, and that removing themselves for the betterment or the immediate family or the social group is somehow accepted. One classical example would be a soldier going to the war field knowing that he probably won't return. Or in the current context, some people might use this example of some of those workers, the so-called COVID workers, working knowing that they are more likely to be infected. Egoistic suicide, on the other hand, is more like when a person's social isolation that leads a man to destroy himself, that he doesn't have much of integration with the society. He's alone. For example, he lost his job and no one there to look after him, or he hasn't anybody to go to or relate to. So that's a very important model to remember while we discuss about the societal causes of suicide. This slide shows about the circumstances leading to suicide. Remember the one in pink, it shows that the current known mental illness or mental health factors contribute to a whopping 50%. Half of people, those who attempt to kill themselves, have got mental health reasons. In fact, those who have killed themselves also would have psychiatric reasons. So that is potentially preventable, and that's the importance of this slide. As you can see, a significant around one-third, more than one-third people have got suicidal thoughts or plans, and many people, around 30% people, over the 30% people, they present with crisis or upcoming in the past few weeks. Intimate partner violence, like the domestic violence, also could be a factor in 27%. Physical health is responsible for more than 1/5 of suicide. Chronic pain, for example, physical debilitating illnesses might be also responsible factors. Alcohol and drug abuse, again a significant factor. If you club this together, that is coming to be more than 1/3 of the total cause of suicide. Interestingly, only 10% are related to job loss, although we are not diminishing or telling that those factors are not important, but the total factors, as you can see, in comparison to other factors, job loss contributes only to 10% of people trying to kill themselves. Next important thing is suicidal risk assessment, because this is the bedrock on which a person, a clinician, is tested. If he or she can prevent a suicide from happening, probably that will be the best that he or she can do. I love this slide. It talks about the case approach, the way you assess suicidality in a clinical interview. CASE stands for Chronological Assessment of Suicide Events, CASE, a very popular model, especially among the psychiatric residents. It talks about sequentially how to explore the present suicide event. Somebody talks about suicide, this is how you should do. Talk about recent suicide first, then past suicide event, go back there. Then talk about immediate suicide events, what's happening right now, feelings, ideations, intent that arise during the interview. It is also important to use techniques which are more flexible interview technique, as they call, while eliciting suicidal ideations, because they are very private and painful ideas that people have. Some techniques, as mentioned here, called same attenuation, to pose a question in a way that you don't make the other person feel shame or feel guilty. Symptom amplification, it uses a person's natural tendency to minimize or downplay quantitative information about behavioral problems. For example, you might ask how many times you cut yourself. The person usually tends to minimize it. So our job is to amplify it. So if you suspect that maybe he's doing it a couple of times in a day, you might ask, it's just an example, that, oh, well, do you use it almost 10 times, 15 times in a day? Oh, doctor, no, not that much. I do it maybe 3 times, 4 times. That gives a more accurate picture, and sometimes it's also used in substance abusers. Normalization is another technique. Talks about normalizing the behavior to help someone feel less ashamed or anxious about it. One example could be, you can start like this. See, it is not uncommon for people when they are stressed out to think about hurting themselves or killing themselves. Have you had thoughts like that? So you are putting it in the context that it is not uncommon, it is normal possibly people to think that way. So these are the techniques to assess or to elicit suicidal ideations, even if they are somewhere there. Because once we know about it, we can do something about it. Unless you ask, well, we cannot do much. The risk factors for suicide, there are plenty, as you can see, starting with the history of substance abuse, physical disability, or losing a friend or family member, the so-called copycat suicide. You must have heard in recent terms, some celebrity, young celebrity killing himself or herself has resulted in many of his fans resorting to that means, especially common among young children who are more influenceable. Bullying is a cause, again, in the younger school-going children. Mental health conditions we have already discussed. A significant percentage of them have got suicidal intent or suicidal thoughts. Death of a family member, access to harmful means, and the relationship problems also are causes of suicide. I mean that they contribute as the risk factors for suicide. Warning signs. This is important to know about it because those are the immediate signs that will be helping you to make a decision whether you admit the person into a hospital or let him go. Very often the clinicians are confronted with this question whether the person should be kept in the hospital or he should be let out of the hospital and live in the community. That depends upon the warning signs. If a person is highly suicidal, obviously he should not go out, he should be kept in the hospital, medico-legally as well as ethically. And in the next slide, they have basically divided into different clusters. I like this slide. It talks about talking, behavior, and mood. Talk, it comprises of people, those who are likely to kill themselves, they often talk about it, as we discussed, experiencing unbearable pain, killing themselves, and having no reason to live. So they don't keep it inside. More than 80% of the cases, as we discussed, they talk about it. We should be there to listen and identify that it's an early warning sign of suicide. The mood is predominantly depressed in majority of the people, those who are likely to kill themselves, or very important feature is loss of interest. Suddenly the interest has been lost. They become irritable, they feel excessively anxious. Those are again the early warning signs. Some people believe that the combination of low mood and anxiety sometimes works as a catalytic event, because in depression person is thinking about suicide, but he or she doesn't have the energy to do that. But when they become anxious, the anxiety has got a psychomotor component. When it's combined with depressive thoughts, that makes the person more likely to resort to the act. Behavior, there are multiple behavior which can be observed. For example, withdrawing from regular activities, acting recklessly, sleeping too much or too little, aggressive behavior, visiting or calling people to say goodbye. Those are the early warning signs that must be taken seriously. When we talk about suicide, very often in clinical settings, people use some scales. You may not be able to use it all the times, but scales sometimes give you a structure which, if you follow, will be able to assess suicidality in a better way. Sad person scale is a very popular scale being used by psychiatrists or even social workers, clinicians, mental health clinicians. S stands for the gender, sex of the person. Females are more likely to attempt suicide, but males are more likely to choose a more deadly means. They haven't told that they will be completing suicide. Age, a particular age group, as you mentioned, 15 to 24 years, and people at the extremes, like after 75 years, are more prone. Depression and P for previous attempts. E stands for ethanol, or the alcohol and other drugs. R stands for rational thinking loss, they are not able to think clearly, and social support being loss of social support or lack of social support, and they often have an organized plan. Suicide plan is another harbinger for suicide act, and no spouse, no relationships, and sickness are antecedents to suicidal acts or suicidal behavior. It's not enough just to talk about risk factors or the early warning signs. It's important to also know the protective factors in a person, so that you'll be in a better position to know the interplay of the risk factors and protective factors and how they act ultimately leading to suicide. To predict suicide, you need to know about protective factors as well. So connecting to other people like the parents or the non-parental adults is very important. School safety, the person when he or she goes to the school, how is the environment and is it a risk factor or not, that also have to be kept in the mind. Sometimes that also helps people protecting themselves from self-harm or suicidal acts. Closeness or the caring friends, asking about them, do you have a close friend, goes a long way. Resilience, overall resilience. Resilience is a physical term often described as the ability of an element to go back to the previous shape. It means in the mental health, resilience is defined as somebody's ability to go back to his previous mental state even after there is a trauma, there is an upsetting event. The neighborhood, I always talk about which neighborhood the person comes from. Certain neighborhoods have got more suicide risk than the other. Access to health services is important. As you all know that people in faraway places, for example, they don't have access to health services. That is not a protective factor. So having access is a protective factor. Academic achievement, traditionally high academic achievement has been mentioned, has been touted as a protective factor, and parental connections, as I mentioned earlier. So at the end of the day, you have assessed the risk, you have looked at the protective factors, then you came to know about the immediate plans, immediate behavior, the intent. This is the time to conglomerate everything, to mix everything and think in your mind to make a so-called clinical formulation, and that will decide what you will be doing next, whether the person will be admitted to the hospital or the person will be sent outside, and what level of care the person needs depends upon this clinical formulation, which is often an induction, a clinical induction that you make in your mind, looking at risk factors, protective factors, early warning signs, and the immediacy of the suicidal intent or desire. Laws on suicide in UAE. This is again a controversial area. I am not a lawyer, so don't quote me on that. My information is based on what I have gathered working as a psychiatrist in UAE over last 6-7 years, and by talking to some of my colleagues. Till date, UAE law prohibits suicide and suicidal attempts. In other words, suicide is a crime. Individuals who attempt to kill themselves are treated as suspects and are adjudicated, is a legal term. They are basically held liable before the court for misdemeanors. Under a particular section of UAE federal penal law, a suspect who attempts suicide faces a maximum of 6 months in prison and a maximum fine of 5,000 dirhams. So it is still viewed as a crime. So being an accomplice, so suicide is also a criminal act in the UAE. And any person who incites or encourages other person to kill themselves, not commit, as it mentioned here, is also criminally liable. So this is what the law as it stands right now states. However, in general, it has been viewed that the progressive or people tend to believe that suicide attempters should not be punished, they should be treated. It's important to view them as victims than criminals. That's the overarching view nowadays, and people are thinking about amending the law in that line. It's important to make a distinction between suicidal intent and a suicidal attempt. For example, somebody just having suicidal thoughts is not necessarily liable in the court of the law, because most people, for example, in depression, in suicide, schizophrenia, they do have suicidal intent. In fact, some of the studies tell that hovering 70-80% people have suicidal or self-harm thoughts while they go through mental health issues, including suicide. In certain diagnoses, obviously it is more than others. But when somebody has attempted to kill himself or herself, and the attempt is imminent, like he has done it and is willing to do that immediately, that's the time possibly law should be brought into play. Well, there could be a valid reason for that. For example, if you protect someone from killing himself or herself, that will also set a lesson for other people, and they will be less inclined to resort to the same act. But in case of controversies, you are always advised to take the legal opinion. But as of now, make it a point that whether it is an intent or the person has already made an attempt. Dealing with a suicidal patient is the last part of our discussion. Here, this is the overarching principle that we intervene when there is an immediate need. For example, hope and the helplines, the person should be contacted, and we encourage the resilience factors by the factors that can build his resilience. For example, supporting his own mental health needs, providing him due care, that will be increasing the person's resilience. And as a whole in society, we have to do certain things so that we can prevent suicide from occurring. I love this 5-step approach when you come across someone with an emotional pain, and in our context, we're talking about somebody having suicidal thoughts. This is very valid. So every person must be asked, as I mentioned earlier, about this, that are you thinking about killing yourself in one way or other? And as you know, around 80% people, those who are likely to kill themselves, do admit to it. Keeping them safe is the next step. Reducing their access to lethal items or weapons, the places, it is important. You can often ask about that, and very often you'll be surprised to know in real situations they do admit that they have got access to weapons or not. Obviously, the family also can help. Being there and listening carefully and acknowledging their feelings is one of the very essential things that does happen, say in crisis centers or helplines or the so-called suicide hotlines. The ability of you to listen to another person often determines the outcome of the situation. Help them connect. As I mentioned, connecting them with particular individuals, particular organizations is important. Well, the lifeline number given from the United States of America probably may not be valid here. You have to give a local hotline number here, and they do the job. So as long as a patient is willing to be connected, that is a strong deterrent for them to hurt themselves or kill themselves. Staying connected, it's not a once-off job. Following up, finding out what happened is important. Going back to our case that we discussed earlier, the young man who tried to hurt himself, and he was talking about there is no point, and he had given up his prized possessions. We made it a point that he saw his school counselor the other day. We made a safety check the other day, calling his number, that he did that. And at the same time, we are ready. If he told that he was imminently going to kill himself, we are ready to inform the police. which you didn't do at that point in time. So those are the 5 steps, as I mentioned, that you do when you find someone with emotional pain. These are some of the slides I collected from National Institute of Mental Health and Neurosciences, a premier institute in India. They talk about suicide prevention strategies. Seek professional help from a doctor or a counselor. Take up a hobby. Keep yourself occupied. Spend quality time with friends and family. And share your worries with a person you are close to. And seek help to prevent suicide. And they do mention that suicide is preventable, but that is the crux of our possibly last few slides. Can suicide be prevented? People still have got divided opinion on that. We do not know for sure whether you can prevent suicide 100%, although some school of thought believe that yes, it can be. Let's have a look. Suicide is the most preventable cause of death. In a bit of a humor here that they have mentioned, although they didn't answer the question whether suicide is entirely preventable, but suicide is the most preventable of all the causes of death. And as you know, 80% of the times people who kill themselves have given a definite signal or talked about suicide. Hence, suicide is preventable from that perspective. This is my last slide, concluding slide. As we discussed about suicide, the case, the definition, the etiology, how to know the early warning signs, the protective factors, formulation, and the management. We discussed one by one. This slide discusses all those things in a nutshell. I liked it. I'm not going to go to the depth of it, but you can know about the warning signs, ask certain questions, how to elicit it, and certain behavior that you do and certain behavior that you don't. So that, in short, finishes our discussion on suicide today. These are the references that you have for further reading. And remember, it is your ability to talk to the person and the confidence that you instill in the person that will be deciding whether the person lives to see the other day or not. And you, as the clinician, is the central point in the person's decision to kill himself or herself. Hence, never underestimate your role in the progression or in identification and dealing with a person having suicidal thoughts. So thank you. Hope it's been useful.